interested, and this is where I tried to make it more interesting. So last week was sort of straightforward cardiology, function, blood movement, and stuff like this. Today we're going to focus more on EKGs. And again, this is not going to be the be-all and end-all of your EKG education. This is just getting you started in terms of a 12-lead EKG, sort of high level, what to look for, and dysrhythmias and what they would look like on an EKG strip. This is where it can get a lot more complicated and more difficult. So we are recording now, and I'm going to start moving. And so the important thing we need to remember about heart muscle is they actually, each cell in the muscle can depolarize and repolarize on its own. It doesn't really need an external stimulus. The heart muscle, myocardium, has its own, as they say, automaticity. And so those cells, that myocardial fiber wants to contract and beat, if you will, on its own. That's why it's important to have a boss or a leader, think sinus node, to keep all those individual cells doing the same thing. We've talked a lot about atrial fibrillation, where the leader gets overwhelmed, the leader's not able to do its job, and each cell's just doing its own thing, and it's not as effective or as efficient. So again, automaticity in some respects is good, in that the heart will keep beating, even if there isn't a specific impulse. On the other hand, it works a lot better when we've got a leader keeping everybody to the same rhythm, same regular rhythm. Then the other thing is excitability. Again, these are specific cells that have the potential to be leaders and to try to keep all the cells working together in an organized fashion. And again, we talk a lot about depolarization and repolarization of the charges within the cells. And that's essentially what you're seeing on an EKG, if you will. And then finally, conductivity. With these electrical stimuluses, they are able to pass it on cell to cell, which again makes it even more helpful in terms of keeping a regular rhythm and keeping the heart beating well, if you will. And then again, contractility, they want to contract, stimulate, and that's what allows the heart to be the pump that it is. In many cases, the autonomic nervous system is controlling. Again, it controls the parasympathetic nervous system. That is what it can decrease the rate of the SA node, and it slows the conduction through the AV node or atrioventricular node. The sympathetic nervous system increases the rate of the SA node, increases the AV node. It also increases cardiac contractility. And again, to me, sympathetic is always fight or flight. That's where things start revving up and start moving. So that's how I remember when you have a sympathetic stimulus, fight or flight, heart rate goes up, anxiety, things like that. That's going to increase heart rate. Again, depolarization is when the cardiac cells become when the cells are normally negative charged, they become positively charged on the inside. And this is where normally the calcium, sodium is outside the cell, potassium is inside the cell. When there's an impulse, depolarization begins and the muscle begins contracting. Repolarization is when the muscle is resetting itself, going back to its baseline negatively charged self. But when you realize the important role that calcium and potassium have in terms of this action potential or electronic potential, you understand why electrolyte balance is so important in cardiology and to the heart. And again, you see depolarization and repolarization periods on the EKG. It's literally what you're seeing. So again, the SA node is the big general, sits up there in the right atrium. There are pathways that conduct electricity down to throughout the atrium, down to the AV node, which sits down at the base of the right atrium, just above the right ventricle. And then that conduction pathway travels down the bundles of His, and they, if you will, bifurcate. There's a right bundle and a left bundle carrying that action potential down, and then all these little Purkinje fibers that again help stimulate the entire area of each of the ventricles. Anytime there's a delay in the transfer of that electrical conduction, again, shows up on the EKG. So if it's, and we know what normals are, and sort of like acid-base balance, when I said you need to memorize those numbers, and again, you haven't heard me say that a lot this year. If you're going to be doing EKG assessment on a regular basis and you're going to do it well, these timing numbers you have to memorize. So we know that it takes a maximum of 0.12 seconds to travel from the SA node down to the AV nodes and to begin that depolarization of the ventricles. You need to know that number, because if it's longer than 0.12, there's a delay in conduction, and that is a dysrhythmia unto itself, known as first-degree heart block. If there's a delay either on the right side of the bundle branch or the left bundle branch, again, that shows up on the EKG in the form of an extra wide QRS complex. You'll still have a P wave in most cases, but you've got this wide, which indicates slower, because again, the EKG is all about time and electrical conduction, and that's called a bundle branch block. And you just have to figure out, based on what lead it's in, is it a right bundle or a left bundle? If your patient has a delay in conduction, let's say they have a known right bundle branch block, that means the left bundle is doing extra work to keep that left ventricle moving, to keep the heart moving effectively. If you develop a left bundle on top of a right bundle, that's a huge problem. You can end up with either, there's a variety of different things. You can end up with asystole, you can end up with complete heart block, you can end up with all different things. So one bundle we manage through. Two bundles gets way more complex. But again, you're seeing that on the EKG. So knowing SA node, AV node, bundle of His, and right versus left bundles and Purkinje fibers are important terms if you want to work with dysrhythmias and EKGs on a regular basis.
Sorry, Carolyn, can you repeat which one was the first degree heart block?
A delay in conduction from the SA node to the AV node.
That's what I thought.
Yep, that's okay. And we'll see that again. All right. So here's your classic EKG, as I like to refer to it, our soap opera EKG. Everybody who's going to die in the hospital goes from this beautiful complex that's well recognizable to flatline, and with rarely anything in between. That's not usually how it works in reality, though. But nonetheless, you've come to recognize this probably even before you came to nursing school. But these are, again, the different complexes and waves that are important within EKGs. The P wave, and the P wave represents atrial excitation. That is when the cells of the right atrium, in particular, to a lesser extent the left atrium, are getting excited and starting to conduct. And you're going to see this is a lead 2. It's always, this is always shown in, usually always shown in the lead 2, as an upright P wave. Then you're starting here with the QRS, which is the big, pointy, spiky complex seen on EKGs. First, there's the Q, which is a little bit below baseline. The R wave, which again in the lead 2 is always upright with 1 point. And then the S, and those represent 3 different points in myocardial contraction. The Q wave represents atrial systole. So that means the atrium is at rest again. It's done its contraction, which was the P, and now it's at rest. The R wave, again, measured from the bottom to this bottom. And again, this is why all systems now have electronic calipers. But if you run a tape and take it as a hard copy, you need calipers. I meant to get my calipers to show you. They are artifacts from a bygone era, because everything's available electronically now. But you would literally measure how many little boxes, because that represents time in EKG world. Anyhow, so the R wave represents the atrial diastole, or when it's contracting.
I have another question, Carolyn.
Yep.
So with the Q, is that like the bump that looks like a hill, or is that like the trough?
It's the trough.
And that's where you measure from the bottom of that for the R.
Well, if you were going to measure QRS, you would measure from the beginning of the downslide, right there, to the end of the S, when it comes back to baseline. That would measure the QRS.
Okay. Didn't you just say something about measuring the R? No, it's okay. But something about measuring from the bottom for the R, or do we not do that?
No, that's just what that represents. The R represents atrial contraction.
So it's the trough, that's the atrial contraction.
Correct.
Okay, thank you.
Jonathan, somebody?
Yeah. Isn't Atrial systole when the atrium contracts, and then diastole is when it relaxes.
Hold on. Oh, you're right. I'm sorry. I'm so embarrassed. You're right. Systole is contraction, diastole is rest. Thank you.
I just had a question I wanted to clarify.
Yep.
So this is cardiovascular, like part 2, but there's no quiz on EKG readings and stuff?
Oh, there is.
Oh, okay. I thought next week's quiz was GI and hepatic, unless I was looking at the schedule wrong.
Yeah, I think, well, that must have been, that might have been an error because this is a new lecture this year that we added, and I may not have forgotten to change the topic of the quiz.
Okay.
But again, while that might sound a little scary, let me say, I guarantee you, any rhythms, strips that you see on the quiz next week, you will have had an opportunity to see beforehand. Is that fair?
Yes, thank you.
Literally, you would have seen seen the strip with its definition.
Thank you.
I'm not looking to mess you up. Okay,
I also have a
so
question.
yes.
So with the, I'm just going back to the P wave.
Yep.
It says atrial excitation. Are we ever going to see the word like depolarization, repolarization?
Yeah, we will.
Okay, because that's how I learned it, so
Yep.
that's how I understand it.
I have another I have other slides that show that, Sean.
Okay.
All right, so QRS, then the T wave. Okay, I'm sorry. S is when the ventricle's getting exciting, getting ready to do its thing. Then again, there's time in between, and you have a T wave, which represents ventricular systole or ventricular contraction. Now here is, again, this is a lead 2 of a 12 lead EKG, and you see the P wave is upright and the T wave is upright. This is a tip or a pearl. In a normal EKG, your P waves and your T waves should always go in the same direction. So we've talked about how with ischemia and potential myocardial infarction, we talk about ST depression, ST elevation, and flipped T waves. When we talk about flipped T waves, it's always in the opposite direction of how the P is going. So if you have an upright P, you should have an upright T. P meaning Peter, T meaning Tom. If in whatever lead you're looking at, the normal P as in Peter wave is downward deflecting, then your normal T as in Tom wave should be downward deflected also. If it is upright, that is a flipped T for that lead.
So question again. So it could be normal for it to be inversed. It would just, that's particular to that person. Okay.
Well, you need to look at the P wave first.
Right. So, but from what we're seeing here, so they could be going up or down, which is normal. But if they're opposite, that's when it's abnormal.
Correct.
Okay. Thank
you. And then the U wave represents ventricular.
Julianne?
Yes.
Sorry. So if they are opposite, if like the P wave is up and then the T wave is down, I know you said that that's abnormal, but what does that really indicate?
It usually indicates some sort of ischemia in the left ventricle.
Okay, thank you.
You're welcome. And then the U wave, which I'll tell you, U waves can be very difficult to see. They can be very subtle on EKGs, but if they're there, they represent ventricular diastole or ventricular rest.
Question.
Yep.
I always learned that EKGs only show the electrical activity. They don't actually show like the physical contraction or relaxation. So is it just sort of implied that the systole and diastole is happening at that time? Because I don't know, I always just learned that the EKG only shows electrical activity.
That's correct, Robin. It doesn't show you the quality of the rest, if you will, or even more importantly, the quality of the contraction. But it does show that the electrical conduction of what should be happening from an electrical perspective during those time frames.
Okay, so like because you know that the P wave atrial depolarization, you know that right after that is the atrial systole, but that's, you just know that because the atrial excitation happened. It's not necessarily like shown on the EKG.
Correct.
Okay.
Yes, if I can say, Robin, so that's hard to imagine then, because it shows the electrical activity in the muscle in the atria and ventriculi. So, and it's hard to imagine that the muscles, the whole thickness, the whole wall is electrically active but not moving. So that's I don't. So it's implied, yes, that something is happening. I mean, the contraction is happening.
Yes.
Cool. Thanks.
Okay, so our SA node, again, is the primary pacemaker, the leader of the band, if you will, and it is perfused by the right coronary artery. So again, think about this. If you have a blockage in the right coronary artery, and that's impacting oxygenated blood flow to the to a specific area of the myocardium, that makes dysfunction of the SA node more common when there's a blockage of the right coronary artery. It's not the only way to get dysfunction in the SA node, but if you have right coronary artery blockage, it is one of the signs and symptoms of that type of ischemia. And again, we really like when the SA node and the AV node are coordinated. We know that when you have a coordination between atrial contraction and the ventricular contraction, again, that atrial output, when the atrium contracts, that contributes, it says here, 25 to 30% of cardiac output. With atrial fibrillation, where you don't have efficient contraction of the atrium, you could be losing potentially 25 to 30% of cardiac output. This is why patients with AFib might be lightheaded, might be dizzy, might have all those other signs and symptoms. Add to that a rapid ventricular response where the time to fill is even less because it's contracting, the ventricle's contracting so fast. Again, it shows quite a significant potential for decreased cardiac output. Again, from our original picture shows how the bundle of His connects with the AV node and then goes down to the right bundle and the left bundle, and then the Purkinje fibers feed off the bundles, again, to facilitate contraction throughout the ventricles. So this is a great picture of how to measure the different aspects of your QRS complexes. And again, it's a lead to because it's so easy. There's your P wave. So your PR interval begins at the beginning of a P wave and extends to the beginning of the Q wave. The QRS from the beginning of the Q to the end of the S. The QT interval from the beginning of the Q to the end of the T. And then here's your ST segment, which we measure sometimes but we're more concerned, is it at baseline, above baseline, or below baseline? I think that that's the more important aspect of the ST segment. But PR interval, QRS width, and QT interval are very important timings when you're doing EKG assessment. Now you got the EKG boxes, the strips, if you will. And if you look at EKG paper like this, you can see it's made up of, if you will, bigger boxes and little boxes. And each little box is 0.4 seconds. And there are 5 little boxes to make up the big square of a big box. So again, 0.4 times 5, you end up with 0.2 seconds. And so horizontally, you're measuring time. What's it called? Not latitude, horizontal, and
Vertically.
Vertically. Thank you. Vertically, you're measuring volts or electricity, if you will. Again, if you're going to go into EKGs and you're going to work in the EPS lab, electrophysiology lab, the voltage is going to mean as much to you almost as the timing. But for those of us not in EPS world, there are only a couple of things we look at voltage for. But understanding what these boxes mean on EKG paper is really important, and is, again, helps you measure the timing of the different waves through the EKG. So again, little box, 0.04, big box, which includes 5 little boxes, 0.2 seconds. And so again, every 15 large boxes represents 3 seconds. Think back here, 15 times 0.2 seconds. You do that math, you end up with 3 seconds. And there is usually a horizontal line that measures that. Again, with electronic calipers, or when you have calipers, you can usually make those measurements more easily. And of course, electronic calipers, you move your measurement sticks, and it calculates the time unto itself. You don't even have to count it. So one of the ways to do a quick count of the heart rate is to, if you know how long, excuse me, if you have a 6-second tracing, you can count the number of heartbeats within that 6 seconds. So for instance, we've got 1, 2, 3, 4, 5, 6, 7, 8, essentially 9 QRS complexes in a 6-second period. There happens to be 60 seconds in a minute. So if you take that 9 times 10, in this case, it'll equal 90. You know this heart rate is approximately 90 beats per minute. That's not exact, but approximately 90 beats per minute. But again, it shows you how the timing of these squares and the length of your strip can be helpful. There's also the rule of 300. You have a lovely QRS, a peak R that's landing on a big box. And then you can, again, remember this, it's not an algorithm, this pattern, but 300, 150, 100, 75, 60, and 50. Wherever the next QRS is, so one big box, if there was a QRS here, the heart rate would be 300. If there was the next QRS was here, it would be 150, 100, 75. In this case, it's between the 75 and the 60. So you know this heart rate is somewhere between 60 and 75 beats per minute. Again, not exact, but it allows you to look quickly. And again, I hate to say it, in the olden days, you didn't have telemetry everywhere. Every patient wasn't on telemetry. So you did a 12-lead EKG to get a baseline, and then as people were running for other equipment and stuff like that.
So those are just two different ways that you can average or like get an estimate of the heart rate.
Exactly, yes.
Okay.
A dysrhythmia implies that it's not normal, that it's either irregular or it's fast, it's slow. So again, when we're talking about EKGs, we talk obviously a lot about dysrhythmias. Arrhythmia actually usually refers more specifically to something without a rhythm or something that's truly irregular. And we usually start by knowing that the impulse of the SA node, the normal range, if the SA node is working as expected, which is the primary pacemaker, it is going to beat between 60 and 100 beats per minute. That's just what we expect of the SA node. Therefore, when it's less than 60 or above 100, we consider that a dysrhythmia. It could still be very regular, and that's whether we call it sinus bradycardia or sinus tachycardia. Our next pacemakers, should the SA node fail in its doing its job, would be the AV node, and the AV node's intrinsic rate is between 40 and 60 beats per minute. So again, the SA node's not doing its job. The AV node should take over and be at least 40 to 60 beats per minute. If you don't see P waves and it's yet you have more QRS complexes more frequently than 40 or 60 beats a minute, well, you know more impulses are getting through and stimulating the AV node from the atrium. It's not just the AV node taking over the role of the SA node. And should the AV node fail, the His-Purkinje fibers have an intrinsic rate of 20 to 40 beats per minute. And again, you've got right-sided His-Purkinjes and left-sided, so you're going to have a very weird-looking QRS complex, but nonetheless, again, this is that intrinsic excitability and contractility and conduction of each of those different pacemakers and tissues. So again, when all else fails, that myocardium is still going to want to repolarize, depolarize, contract, and rest to the best of its ability. So again, sinus node, we talked about sinus bradycardia and sinus tachycardia. You can get premature atrial contractions And so what happens is a rogue impulse gets through to the AV node and causes a contraction. It's just an isolated contraction. It looks different from some of the others. It's not, it's at an irregular, unexpected point in time. And it didn't come from the SA node. So it's probably not going to have a P wave. Paroxysmal atrial tachycardia. So this means, yeah, there are usually P waves, but they are just really stimulating the ventricles, and you've got significant tachycardia. Atrial flutter, well, the SA node is losing control, but they're trying to keep it together, and you get a sawtooth pattern. So it's not true P waves. You see something there, but again, it looks more like a sawtooth than nothing or a P wave as expected. And again, with the sawtooth, every once in a while, you're going to see a QRS complex. Then you have atrial fibrillation where you see no P waves, there's no organization up in the atrium, but yet we're seeing QRSs based on the different impulses that are coming out of the atrium that are making its way down the AV node, down the bundles. And so you are getting QRS complexes.
Sorry, quick question.
Yeah.
Since both atrial flutter and atrial fibrillation were AF, you wouldn't see that on a chart because it's two different things,
We
right?
usually say AFL.
Yeah, and I've seen AFib, yeah,
Yeah.
not just
Or
AF.
A flut, but you're right, that's usually what they'll say. And A flutter is slightly more organized than atrial fibrillation, but definitely not a normal sinus rhythm.
So quick question again. So basically what you're saying is like atrial flutter is like, if it gets worse, it'll become AFib. Like it's
Correct.
the beginnings of it. So they are related. Okay.
Yep, correct. And most people don't stay in sustained A flutter. It degenerates to atrial fibrillation. I say relatively quickly. You don't see a lot of folks in chronic A flutter. You see people in chronic AFib though. I'm not saying it's impossible, but it's much less common. On the ventricular side, you have premature ventricular contractions. So again, the SA node's working, the AV nodes are working, everybody's doing their thing. You've got nice regular rhythm. There's a P, there's a QRS, there's a P, there's a QRS. And then all of a sudden you get this wide, bizarre thing. You're like, it's not at a specific time. It looks different from everything else. What the hell is that? And it may be one, it might be every third one, every other one. Oh, you know, you got all sorts of options. Well, it may be a premature ventricular contraction. That's some cells in the ventricle just saying that they want to be the leader, and they just do their thing, and you end up with this big, weird looking QRS complex. And again, it looks different from the others because it's not following the same conduction path. It's a different conduction path. And anytime you go off the AV node bundle of His Purkinje pathway, takes a lot longer to go cell to cell than following those pathways. And when it takes a lot longer, you get wider complexes. And that's a classic hallmark of a PVC.
Carolyn,
Yes.
is it with the PVC that you get bigeminy or trigeminy? That you get the 2 or the 3 in a row?
Yeah, yes.
Will we need to know like that in depth or no?
You might.
Okay.
Jill, Hank, on bigeminy, isn't that where the irregular rhythms are regular? So the difference between AFib and bigeminy is AFib is irregular, and bigeminy is irregular.
Well, yeah, bigeminy usually mean, well, it could still be, it's did you say regularly irregular, James?
Yes.
Yeah.
Yes.
Yeah. So, and I believe I have a picture of it later. So what bigeminy is, bi meaning two, you have a PVC with a normal complex, PVC normal complex, PVC normal complex, PVC normal complex. So in the normal, and you know how much I hate that word, but you've got your P wave, your QRS, your T wave, and then you've got a PVC. Then you've got P, QRS, T, PVC. So you're right, it is regularly irregular. Your PVC may also be, again, remember, it doesn't have its atrial kick. You're losing cardiac output. So not only may the rhythms be noticeably irregular, but in palpating their pulse, a ventricular, a PVC may not push blood as effectively out to the pulses. So you may have strong impulse on the pulse, like your fingers are feeling something strong, then it's less strong. Then it's strong, then it's less strong. So not all of these contractions are as effective in terms of getting blood out to the periphery. Ventricular tachycardia is when you've got a whole string of PVCs together. It's on a run. And you can have it's not considered ventricular tachycardia until you have 3 PVCs in a row. That's not to say bigeminy, and then trigeminy would be every third, 2 normals and a PVC, 2 normals and a PVC. So that's what we talk about with bigeminy and trigeminy. If you have 2 PVCs in a row, it's known as a couplet. 3 PVCs in a row, known as a triplet. Once you get 4, now you've had a run of VTAC, a 4-beat, 5-beat, 6-beat run of VTAC, whatever it was. Or if it goes much beyond that, a 10-second run of VTAC, 15-second run of VTAC. We usually stop counting after 5 beats, and it becomes the time frame that the ventricular tachycardia lasted. Depending on the patient's response to ventricular tachycardia, they may be conversant, they may have a blood pressure. I would make sure they're in bed. I would make sure they're safe. I would prepare for the worst. But depending on how fast it is, how the patient responds, it's not a good long-term plan. It's not even a good medium-term plan. But short-term, you may have a responsive patient. Ventricular fibrillation, just like with atrial fibrillation, that means your ventricle is completely disorganized. This patient has no discernible pulse, has no discernible blood pressure, and ventricular fibrillation is a non-life sustaining rhythm. It is a full-out emergency. But you have cardiac activity, which is important to note. Do you see the difference between ventricular fibrillation and everything else we've talked about so far? I'll take that as a yes. Other conduction abnormalities. First degree AV block. We talked about first degree. That is where it is taking an extra long time for the conduction to get from the SA node to the AV node. So you have a prolonged PR interview. It is longer than 0.12 seconds. Second degree AV block. There are a couple of different kinds. And again, it has to do with the timing of getting the impulse from the SA node to the AV node. We'll talk more about second degree AV block. Third degree AV block. The SA node is doing its thing. The AV node is doing its thing. And they are not talking to one another. So there is no relationship between the P waves and the QRSs. P waves are marching in on a regular basis. Your QRSs is marching along on a regular basis, and the two are not related at all. Again, not a good medium to long-term plan. You got to fix that. Ventricular asystole. No electrical conduction through the ventricles. If you thought cardiac output was bad when you lost your atrial kick, when the ventricle doesn't contract at all, we have real problems. And it means there's no electrical conduction through the heart. You cannot shock asystole. Defibrillate, however.
Hey, Carolyn,
Yep.
just for clarification, when you talk about like PEA and asystole, in the case of asystole, it's the ventricular asystole. There's no such thing as atrial asystole. I'm just asking.
I've never heard of it. I do think atrial fibrillation is almost as close as you come, but there again, you're right. There is atrial conduction, even in atrial fibrillation. You will sometimes see, again, an SA node doing its thing. You'll see P waves across an EKG with no ventricular response. That's still considered ventricular asystole, though.
Okay.
And AV dissociation. Now I'm having a brain spasm. What's the difference between third degree and AV dissociation? Complete heart block. We're going to have to come back to that. Obviously, I won't test you if I don't come back and clarify that.
Isn't third degree considered the same as heart block, like complete heart block?
And AV yeah, third degree is complete heart block, but then what's AV dissociation? And I think third degree, complete heart block, and AV dissociation are all synonymous. I just can't remember right now, Linda. I'm sorry to say. All right, so now you want to look at your EKG. Your first step is to calculate your rate. And when we calculate rate, we're almost always counting our QRSs. Then you want to determine if it's regular or not. So that's, are the QRSs happening in the same time frame repeatedly? Step 3, let's look at our P waves. Do we have P waves? It's a great place to start. Are they regular? Again, you have to map this out. Then you measure your PR interval. And you measure the width of the QRS, or width and duration in this case are synonymous. So you figure out your rate. Is it bradycardic, as expected, or tachycardic? Is it regular, regularly irregular, or irregular? Are there P waves associated with each QRS? If they are associated with each QRS, what is the PR interval? And what is the duration or the width of the QRS complex? Those are your first 5 steps. And like many of the things we do, You need to develop a system for this so that you don't forget something. So this is sort of typically what's recommended in terms of assessing your EKG.
Carolyn,
Yes.
not to get too far ahead of myself, but because this one will take a little bit longer to interpret each EKG strip on the exam, would we have a little bit longer of an exam duration? Like, would we have longer than 20 minutes for this exam?
I'll take that under consideration.
Okay, thank you.
I'm not
Right.
looking to necessarily, I just sort of want you to get some experience, right?
When in
Yeah.
the field, when you do like an EKG, isn't there most of the time like a box in the corner that essentially tells you all those values that we just saw? Like PR interval, heart rate, QRS duration, QT interval.
Yes, Jack, nowadays there are.
So we're just
It wasn't always like that. And you will still see your cardiologists sitting down with calipers and measuring this stuff out. You know, it depends on the baseline, it depends on it. And again, when you're looking at a rhythm, that's if you have a 12 lead. But if you're looking at a rhythm strip, no, you don't have that. You need to calculate that. And if you're on a telemetry unit or an ICU, well, certainly telemetry, you have to document what the telemetry is showing with these numbers at various points throughout the day. And whether it's done by a monitor watcher or the nursing staff, that depends on the hospital's policy. So again, this is again, looking where you start measurement of does that make sense, Jack?
yeah. I know it's like super important to understand it all. I was just wondering because I like was questioning what the ones I've seen or not.
Yeah, you're right. It's there in a 12 lead. It's not there if you're doing a rhythm strip. So again, you look at this is a rhythm strip, and this is your lead 2, which is very nice. You know, your P waves are beautifully upright, got a nicely defined PR interval. You can measure your QRS. It's even easy to measure your QT interval. This is a different lead. I'm not exactly sure which this one is. But again, same heart, same rhythm, but you can see how the conduction through at this point in time looks different electrically. Still have a P wave, still have a QRS complex, still have a T wave. But and interestingly enough, in this one, look at that ST segment. This is what you would call the baseline. Is that ST segment elevated above the baseline?
Yes, 1 millimeter.
Yeah. And so again, if this was marked, you would know which lead this was in.
That's AVR, most probably.
AVR?
Yep.
All right.
And if the upper one is the second one, probably.
Right. And that usually gets marked even on a telemetry. All right, so here's normal sinus rhythm.
Again, well, maybe that's V1.
I was going to say V1 with it was what I was one of the V leads.
Yeah, because
we'll show 12 lead. We'll show our wave progression, right, Eugene? When we get to the V1 through 6.
Since we see biphasic P wave, so that's probably V1 because at an AVR it should be negative, like completely. And here we see plus minus at P wave. Yeah, but okay, that's the detail. These are.
So here's our normal sinus rhythm.
Yep.
And again, using our steps, first we want to do is calculate the rate here. And again, we could use that, the 300 method. We can count the number of, we don't have, do we have 6? I don't think we have 6 seconds here. We want to look at our, so we want to calculate the rate. What do we want to do? We want to determine the regularity. Well, determining the regularity would be measuring each of these QRS complexes to make sure they are evenly spaced out, which yes, they are in sinus rhythm. Then we want to look at our P waves. And we look here, and we've got a P wave for each of the QRSs. That's always a better option than not. We can measure our PR intervals and our QRS intervals. So again, in normal sinus rhythm, the heart rate is going to be between 60 and 100 beats per minute because the SA node is the leader. There is 1 P for every QRS, and it is regular. And each of those P's and QRSs look just like the one before it. They're identical. And your PR interval is going to be 0.12 to 0.2. So I misspoke earlier. I said a first degree heart block was when the PR interval was longer than 0.12. I'm sorry, the PR interval slowest is, or fastest, I should say, is 0.12. So you have first degree heart block when the PR interval is greater than 0.2. Sorry about that. But again, you would measure 2 or 3 of these complexes to make sure you have identical, similar timing. And again, your QRS should be less than 0.12 seconds. That's how long in a normal conduction pattern it takes to travel throughout the ventricles. So again, heart rate between 60 and 100, a regular rhythm, 1 P wave for every QRS with a PR interval between 0.12 and 0.2 and a QRS less than 0.12 seconds. Those are the parameters for normal sinus rhythm. So just to, as a precursor or anticipation of next week, you might see a picture of this rhythm, and it will be, what is this rhythm, via multiple choice. Might be that simple, might not be that simple. So again, here's another rhythm strip. Again, you can calculate the heart rate here. Using whichever methodology. And again, you see P wave before the QRS in each of these 3 complexes. And if it's regular versus irregular, again, you're measuring that peak R wave to make sure it is equal and regular. And you know, if you don't have calipers, you can always take a piece of paper, mark one, mark a second one, and then move the paper along for practice. And again, the other option is when you go to clinical, try playing with the electronic calipers to see how those work for your patient. Again, the P wave is usually atrial function. The QRS is the ventricular response. And that R to R is the ventricular response and the ventricular rate. In this scenario, we've got P waves before each QRS. The P waves look identical, complex to complex. They're occurring at regular intervals. Again, you determine that by measurements. There's only one P wave for every QRS. And then you would measure the timing, the PR interval. Again, measuring the PR interval is important from a first degree or normal sinus rhythm perspective when you have a normal, regular P wave. You still need to know that PR interval before you can call it a normal sinus rhythm. When we're looking at the QRS complexes, again, we like them to look all the same. That means they're following the same electrical conduction pathway. They're pointing in the same direction. They're measuring less than 0.12 seconds. When they're prolonged, it can mean there's a bundle branch block or the impulse is starting somewhere else within the ventricles, or maybe they're a PVC or some other odd complex. And again, you need to measure the QRS duration from the beginning to the end. It should be less than 0.12 seconds. Now, you can still have a sinus rhythm. As we said, you're still going to have one P for every QRS. You're going to have a normal PR interval. You're going to have a normal QRS duration. But if the rate's greater than 100, it's sinus tachycardia. It's still starting within the sinus node. The sinus node is still operating as the leader, but it's faster than the normal 100 beats that's expected. Same for sinus bradycardia. You still have one P wave. They look all the same. The PR interval is within normal limits, less than 0.2. The QRS is within normal limits, less than 0.12, but it's a very slow heart rate, less than 60. But again, the sinus node is still the leader. It has all those other qualities of normal sinus rhythm. It's the rates are either less than 100 or greater than 100. We look a lot at the QT interval. I talked about this, I think last week or at some point in time, because there are a bunch of medications that can prolong the QT interval. And the more you prolong the QT interval, the more prone to either ventricular tachycardia or ventricular fibrillation a patient can become. As it says here, it's a little controversial in terms of what a normal QT is because it's rate related. So you need to know what the patient's baseline is at a certain heart rate and then track it over time. Again, based on heart rate. So if you have a patient who had a QT interval of, let's say, 0.4, when their heart rate was 80, and you start a medication that has the potential to impact the QT interval, and the next day you come, or 2 days later you come, and their heart rate's still 80, but their QT is now 0.5, that's a problem. That medication is probably impacting their QT interval. So you want to try to get them at a similar heart rate. You know, if they're more tachycardic at 100 or they've slowed down, there may be some adjustments to make, and that's where the 12 lead is very helpful because it can adjust QT interval for heart rate. But just be aware that all things being equal, prolonged QT intervals can be a potential risk for either ventricular tachycardia or ventricular fibrillation, and there are many medications that can impact the QT intervals. So as I said, there's the correction. You can try figuring that out, but to me, that's where 12 lead EKG analysis has been very helpful. We worry, we watch them with sodium channel blockers in certain electrolyte disorders, hypothermia, acute myocardial infarction, increased blood pressure. And again, this is almost like a critical lab result because of its risk for VTAC and ventricular fibrillation. So there are premature atrial contractions also. So again, we're looking at this rhythm strip, and is it regular? No. You've got something happening here, and you got something happening here. We got a nice little block there that gives us hope, but we need to figure out what's going on here. For these other that look the same, we got a nice P's, they look the same. We have a regular R to R measurements for these. And what often happens in PACs, this R to R is often double one of these, implying that this one is obviously premature. But also look here, the P wave looks different. It's not the same as these other more normal. So again, do your rate calculations, look at your P waves, note the difference for these contractions. The QRS, though, look the same. They have the same morphology. Just like you talk about cell morphology on a biopsy, we talk about conduction morphologies and EKGs. And I bet you this QRS duration is the same as these. So and since there is a P wave here, and you can see here, as Eugene was saying, it's it's not biphasic, but it's half upright, half going down. It implies that this impulse did not come from the SA node. It came from somewhere else in the atrium. So it's still an atrial generated QRS response. It's just not out of the SA node the way these others were. And it's early or premature. So that's what a PAC can look like. Down here, you've got, again, nice P waves, all looking the same. QRSs have the same morphology each time until we get here. It's got a downward deflection. It's got an exceptionally wide duration. It's early. There is no sign of a P wave. And this is sort of your classic PVC, wide and bizarre and early, with no signs of a P wave. So again, premature atrial contraction, it's starting in the atrium, but someplace other than the SA node. It's got a different pathway, not using the SA to AV node pathway, which makes it look different than the classic SA node generated impulse. The ventricular impulse started the same way because the QRS morphology was the same. But again, in this case, it was early and looked different. What causes PACs? Well, stress, fatigue, caffeine, tobacco, alcohol, hypoxia, electrolyte imbalances, different disease states. We usually start the patient by, saying, let's get rid of some of these stress factors and other risk factors. Depending on the patient's response, they may feel palpitations. They may feel like their heart skipped a beat. Again, try to have the patient modify these risk factors, whether it's meditation or dealing with stress in some other way. Make sure they've got good sleep hygiene and they're getting enough sleep. Limit caffeine, ditch tobacco, moderate alcohol. Check our O2 sats to make sure there's nothing respiratory going on. Correct any electrolyte imbalances. If they continue, you can try beta blockers. Probably the most classic is metoprolol. But they don't often need much more treatment than that. So again, we know an occasional abnormal focus is a PAC. I should say an abnormal atrial focus is a PAC. When you get multiple abnormal firings, you can end up with atrial flutter. And here is that sawtooth pattern I mentioned with atrial flutter. And atrial flutter tends to be actually regular. This happens to be a 1, 2, 3, 4 to 1 pattern where there's 4 flutter patterns with 1 ventricular response. And that ratio can change depending on how often the flutters are getting through either to the AV node or to the ventricle. And so it can change the rate of ventricular response. Atrial fibrillation, again, we're looking at this. We're going to determine its rate. We're going to look at its P waves, and we say, uh-oh, we don't have any discernible P waves. Check a different lead. Again, no discernible P waves. Look at, we have irregular ventricular response to atrial stimulation. So our QRS regularity is not so regular. We have actually irregular QRSs. And that's classic atrial fibrillation. Ventricular response is said to be slow to rapid. It's all what gets through the AV node to the ventricles. It's irregular. It can either be fine or coarse. This would be a good example of fine. This looks more coarse. But again, there's no discernible P waves. There's no PR interval to measure. But our QRSs in this example are of normal duration, less than 0.12. And the preference with atrial fibrillation is to get the patient back into normal sinus rhythm, if at all possible. That can be done with medications, can be done with electrocardioversion, but you've always got to make sure that you either need to know when it started so you can determine the chances of having blood clots formed in the atrium, because again, if that atrium, after fibrillating for some period of time, all of a sudden gets regular and has good, strong contractions, any clots that were formed can just now have a greater chance of moving through the system and wreaking havoc further out the system. So again, this is why we start anticoagulants. It's why we do TEEs or TTEs before we cardiovert patients. And it's even why we do those things before we try to chemically convert them with drugs. If you're unable to convert a patient to a sinus rhythm, then at least control the ventricular response. You don't want a patient having rapid ventricular response for prolonged periods of time. Let's try to get it more slow so that they don't feel palpitations. There's a better chance of better ventricular filling, giving it time to fill. Even if we don't have effective atrial contraction, we can have better ventricular filling if it takes the time to fill before having another contraction. And then cardiac ablations are considered long-term, not 100% sure they'd consider it curative, but it can be curative. It's where via an EPS procedure, little areas either in the pulmonary artery or in the atrium are, they believe that's where the foci is causing the atrial fibrillation, and they literally cauterize it, or actually now they cryo freeze it more than cauterize. They use cold versus hot. They have much better outcomes to tamp down the foci, leading to normal sinus rhythm. And it can be very effective. Like I said, they hope it's curative, at least for a medium term, like years for some people, if not forever. But again, we've talked about anticoagulants, and rate control. If you can't convert them, those are the two most important things with atrial fibrillation. Here's another picture of a flutter. The atrium is moving pretty fast. It's slightly more organized than atrial fibrillation, but not by much. And the ventricular response, again, you've got QRSs here that all look the same, but we have an irregular response to the atrial impulse. This is a 1-to-1 flutter. Here is 3-to-1. So this patient's still going to have an irregular heartbeat. In this case, it can be regular or it can be variable, but it's that sawtooth pattern that's so classic. And in this case, your QRSs, again, because the QRS stimulation is coming out of the AV node, looks consistent. QRS durations less than 0.12. I don't think we need to belabor AFib, A flutter much longer. And again, it's that 24 to 48 hour period. So if you don't know when AFib started, you need to err on the side of caution, start anticoagulation, do your ultrasounds to make sure there are no clots before you go and try to convert these folks. So when the AV junction tries to take over, it can try to be the leader of the band. And if it, again, it ends up with this re-entry looping circuit, you end up with supraventricular tachycardia. So we talked about ventricular tachycardia briefly. Supraventricular tachycardia means it's not starting in the ventricle, it's actually starting in the AV node, which means it's going to be more narrow. The QRS duration is going to be shorter than if it was starting in the ventricle, but it's very fast. And it's not responding to the SA node stimulation. It's doing its own thing, if you will. Most junctional rhythms or AV junction rhythms are in the 40 to 60. Again, a supraventricular is higher than that, which what makes it a dysrhythmia. And again, it's starting in the with a junctional rhythm. In this case, it can go both forward and backward, or antegrade, as they say. So in this case, you've got a P wave occurring after the QRS. And that's sort of a hint in this rhythm that it's junctional, not a sinus rhythm, or not a complete heart block, because these are actually related. It's just after the fact. I've never seen an EKG like this in real life, but just they are possible. But the real takeaway here is that a junctional rhythm, if there is a P wave, it's often retrograde, meaning after the QRS, and it's typically 40 to 60 beats per minute. That's that intrinsic rate of the AV junction. Premature ventricular contractions, again, could be stimulants like caffeine, cocaine, other things like that. There are many other stimulants. Those are the two that come to mind. Electrolyte imbalances, hypoxia, other heart disease, ischemia. Again, you've got some focus in the ventricle that's trying to take over. It gets started, and you get a wide, long duration, weird looking complex on the EKG. almost everyone feels like they've had one. If you've ever had it feel like, again, we talked about PACs feeling like you skipped a beat. PVCs can feel like that also. But one of the hallmarks is the QRS is wider than 0.14. It takes, again, because it's not following the bundles of His right or left or Purkinje fibers, it's plotting its own course. It's going to take longer to travel through the ventricles, which means it's going to be wider than 0.14. And oftentimes the T waves go in the opposite direction as well. And again, we know we need to look at the T's in regards to the P waves also. But again, a PVC should be either a standalone or one of relatively few. So here's one strip of from a telemetry. You got P waves. Yep, that's good. We got nice P waves there. And then you go, what the heck is that? We'll come back to that. Our QRSs are all of the same morphology. We could measure our QRSs here. We could measure our PR intervals. All of this up until this puppy here is as expected, or as we hope, shall we say. Here we've got wide, bizarre, no P wave, no P wave. You know, you kind of look in through the morphology here. And again, if you measured this QRS complex, it is considerably longer than 0.14. Looking at this tracing, well, again, we've got P wave, P wave, P wave, QRS, QRS, QRS. We got, what the hey is that? Oh, we recognize this guy. And then what's this? So again, no P waves, wide, bizarre in both cases, but this morphology doesn't look anything like each other, nor does it look like this one per se. So this is two different foci, two different initiations of a PVC in the same patient, obviously in the same rhythm strip. That can be concerning because that means there's more than one irritated area in the ventricle. You've got at least two trying to fight for control, in addition to the sinus, the AV nodes, and the bundles of His. But you've got two other areas trying to make trouble there. And again, we know that because the morphology is different. They look different. It's called multifocal PVCs. Right, we got to try to find out what the underlying cause is. We don't really want to leave patients with PVCs. We use lidocaine, procanamide, amiodarone. Some beta blockers, calcium channel blockers, can all decrease the occurrence of PVCs and potentially limit the occurrence of ventricular tachycardia. You've got to check your electrolytes as well. All of that's really important. So again, here we've got similar morphologies. We're going to call that a P wave. Again, it's a little half up, half down. These all look alike, but wide and bizarre. Now, this QRS is pretty wide unto itself. So this patient, again, you'd have to look at a 12 lead to confirm, probably has a bundle branch block. What do you think, Eugene? Does that sound reasonable there? At baseline, and has an irritable focus as well.
Yes, looks like that.
Thank you.
Does that also have ST depression.
You know, with Q, that's a great question, Jonathan. With yes, it's ST depression's harder to diagnose with
Left.
bundles.
Yeah.
But it certainly, again, this is why you look at all 12 leads to see what you can see. And it's also why you try to get a baseline EKG on patients before they have their dysrhythmias and changes in their rhythm so that you can get a better sense.
Yeah, that's left bundle branch block, yes, and the ST depression. So we cannot judge it by this because of the aberrant conduction. And
Yeah.
no.
So even different neuro disorders, even in terms of intracranial pressures and things, can impact ventricular tachycardia. Certainly VTach can come from ischemia, electrolyte imbalances. And as I said earlier, you can have a patient, usually depending on the rate, who has a pulse and may have a level of consciousness that can be, well, you can always assess level of consciousness, but may be alert. And that's considered stable ventricular tachycardia, which, believe me, can go unstable very quickly. Or if they're already pulseless, it's known as unstable ventricular tachycardia. What was that? Okay. So again, sustained ventricular tachycardia decreases cardiac output. You end up with hypotension, pulmonary edema, decreased cerebral blood flow, and ultimately, without treatment or even with treatment, if it's not reversed, ends up in cardiopulmonary arrest. And so it is considered a very unstable rhythm that needs to be dealt with. And again, whether it's hypoxia, ischemia, things like that. Stable VTach can be treated with medications or cardioversion. Pulseless VTach needs CPR and then rapid defibrillation. So again, pulseless, while I will argue that both of those are emergencies, pulseless VTach requires CPR to support blood circulation. And again, you've got some other area taking over the focus, acting as a pacemaker. It can be sustained, it can be non-sustained. They can be, as they say, monomorphic, one foci, or polymorphic, different foci. But again, with that decreased level of cardiac output, it is decidedly life-threatening and will move on without treatment to VFib in asystole over time. Again, VTach's 3 PVCs in a row. And here you have a lovely run of VTach on 2 different leads. Again, ventricular rate in VTach is considered usually anywhere from 100 to 250 beats per minute. But I'll be honest with you, again, if it's unstable and the patient's pulseless and unresponsive, I don't care how fast it is, it's still an emergency. We need to start CPR, we need to defibrillate the patient, and we need to correct the underlying problem. P waves are not usually seen in VTach. They're, again, if you were in the EPS lab, they may be able to isolate the P waves, but that's not useful in the real world out at the bedside. But again, wide bizarre. This is all one foci. It's monophasic, not what I want. It's just one foci. All these beats look alike. Again, life-threatening, needs to be treated. Need to start CPR, medications, oxygen, and defibrillation come with VTAC. Sinus tachycardia, supraventricular tachycardia tend to be regular heartbeats. A flutter tends to be regular with an occasional irregularity in it. A fib is definitely irregular, and a flutter with variable conduction is irregular. Your wide complex dysrhythmias, sinus tachycardia with an aberrancy, not necessarily, we don't see that a lot, but just be aware that it can happen. Again, supraventricular with an aberrancy, but ventricular tachycardia is a wide complex dysrhythmia. And there is some irregular VTAC as well. This is my personal favorite dysrhythmia. See how it sort of looks like, where it starts small, gets wider, gets smaller again and wider. And this is just spinning on a helix. What is that? I don't know. This is a ventricular tachycardia rhythm, and it's called torsade de pointe. And it literally looks like a helix just spinning. If you were running a long-term rhythm strip, it's almost elegant in its presentation. This is a particularly special kind of tachycardia, ventricular tachycardia that you see on occasion. And it is very often related. This is what happens with prolonged QT intervals. They're often medication related. These are some of the medications that have been shown to cause, that have been associated with torsade de pointe. And why we keep track of our QT intervals over the long haul. This is actually harder to treat and harder to get back to normal sinus rhythm than a classic ventricular tachycardia. But when you see torsade, I remember the first time I saw it, you were struck by it because it was so different looking from other VTACs that you'd seen. Ventricular fibrillation, again, strongly associated with myocardial infarctions and ischemias. These patients are unresponsive, pulseless, apneic. This is obviously an emergency situation. You need to start CPR in all your advanced cardiac life support procedures. You can defibrillate ventricular fibrillation. There is electrical conductivity there, and we use other medications to try to help corral that electrical activity. There is fine VFib, where it's just the most subtle of movements on the tracing, and coarse VFib. This is a somewhat exaggerated, but you can see it's not regular. You might be deluded into thinking that it's VTAC if you saw something like this, but it's so irregular, it's so inconsistent. This and your patient is not alert, does not have pulses, you cannot get a blood pressure. This is clearly emergency situation. It's, as I said, electrical chaos in the ventricles. And so you need to initiate CPR as soon as possible. AV blocks, your first degree AV block is your prolonged PR interval. We talked about that before, longer than 0.2 seconds. And I said there were a couple of different kinds of second degree block. Mobitz type 1 and Mobitz type 2 are the current names. The Mobitz type 1 is the PR interval gradually lengthens, and then there's no QRS. So you need a good rhythm strip to see the progress of Mobitz type 1 in particular. And Mobitz type 2, you've got a good consistent PR interval, you've got good consistent P waves, but all of a sudden you got a P wave without a QRS. Just all of a sudden missing. It's not premature, it's not late, it's not nothing, it's not just not there. Then again, your type 3 heart block, complete heart block, type 3 AV dissociation is when P's are marching through, QRSs are marching through, and they have no relationship to one another. So here is a third degree or complete heart block. P wave, P wave, P wave. You see the P waves very clearly. You see QRS complexes equally as clearly. They are wide, grossly prolonged, but you also see that there is no relationship between the QRSs and the Ps. The Ps are not causing the QRS response. Significant decreased cardiac output. This is patient needs a pacemaker. Emergently, they'll apply either an external pacemaker nowadays. They might thread a temporary pacemaker in at the bedside, but this patient needs a pacemaker. You don't have an event like this and not go home without a pacemaker. Besides that, our ventricular response is way too slow. Again, this patient is probably lightheaded, dizzy, altered level of consciousness, bad cardiac output, not a good scenario. Again, Winky-Bach is the old name for Mobitz type 1, but if you remember this poem, if the R is far from P, then you have first degree. So again, it's implying you've got a P wave, you've got a QRS, they're just far away from each other. So you've got first degree. Longer, longer, longer drop, then you have Winky-Bach. Again, Mobitz type 1 is the current phraseology. But again, if you map out your PR intervals, they're getting longer and longer, and then all of a sudden, we don't have a QRS response. If some P's don't get through, then you've got Mobitz 2. So again, there you've got what looks to be normal, PQRS, PQRS, P, no QRS. And if P's and Q's don't agree, then you have third degree. Got P waves, got Q waves, and they're not have any relationship with one another. And here we've got asystole, no electrical contractility, no electrical activity, I should say. You need to check to make sure at least 2 leads. This means there's nothing happening in the heart. Atrium, ventricles, nowhere. There's no pulse, cardiac arrest. If VFib is gone too long, or we'll get to PEA, pulseless electrical activity, we'll get to that. But you don't defibrillate asystole. Defibrillation, applying that external electric shock, you defibrillate to reorganize electrical activity. It stops, it restarts, and hopefully comes back in a better rhythm. There's no electrical activity here to reorganize. So you need to get to electrical activity before you can defibrillate asystole.
That's in the name. Defibrillation. So you are stopping defibrillation. No fibrillation, no defibrillation.
Very good, Eugene, exactly. So again, asystole is not, it's in this case, it's not even a good medium-term plan. This is just a bad plan altogether. You've got to treat this, you've got to do CPR, and it has a fairly poor prognosis, to say the least. I think I said all this already. Yep. Now, pulseless electrical activity. I got to tell you guys, this is like one of the scariest things around. You've got a patient on telemetry. You check their rhythm as they're walking by and you see conduction there. You go in to check your patient and they are in fact no pulse, not breathing. And that is what's called pulseless electrical activity. You'll see it as abbreviated as PEA in the medical record quite often. So it implies there's electrical activity, but the ventricles are not responding. There's no contractility there. And so the patient has no pulse. And again, this does not have a good outcome, I should say, because number one, you often don't necessarily know how long they've been without electrical activity. And of course, the longer you're left hypoxic without circulating blood volume, the poorer the output and the more severe the morbidities and things like that. What causes PEA? Hypovolemia, hypoxia, acidosis, both of the kalemias, hypoglycemia, hypothermia. Remember we know hypoglycemia will kill you a lot faster than hyperglycemia will. Hyperglycemia may be an ugly, long, slow death, but hypoglycemia is kind of fast and kind of final. Then there's the T's, toxins, tamponade, thrombosis, whether it's pulmonary emboli or in the myocardium, tension, pneumothorax, and trauma. So the H and T's are of pulseless electrical activity. Now, in general, with PEA, honestly, the EKG or the tracing does not look exactly like the patient's tracing from pre-PEA. It's either slower, it's wider. It's not going to look like completely normal sinus rhythm. But again, if you're just walking by looking quick and you see a tracing, it doesn't often alarm. It's not always that slow. It may be what alarms first is your O2 sat percentage has gone down. Maybe you've got your automatic blood pressure cuff to automatically cycle and it gets a hypotensive reading. That's often what brings help into the room, not the tracing. So it's a little on the scary side, to say the least. You got to start by CPR. And why do we use epinephrine? What does epinephrine do? We use epinephrine for asystole also. I'm sorry.
Right. It's going to stimulate the sympathetic nervous system.
Right. And we know the sympathetic nervous system makes heart beat faster. So we're trying to encourage electrical activity, trying to re-stimulate it pharmacologically versus electrically in this case. What do you think this rhythm is?
Complete third degree.
I agree. What do you think this rhythm is?
Normal sinus rhythm. probably.
Normal.
Yep. I mean, there's definitely, the P's are difficult to discern. If you look at the rhythm strip, it's a little bit easier to see the P waves. But yep. And again, defibrillation is the treatment for ventricular fibrillation and pulseless ventricular tachycardia. The earlier you defibrillate, the better the outcomes in general. What it is, it's an external, in emergency situations, usually it's an external electrical shock that essentially stops the electrical conduction. It reorganizes it, and then hopefully it allows the SA node to resume its role as pacemaker. But you are giving an electrical shock to a patient. So from a safety perspective, we need to make sure no one is touching the bed. Our beds are still metal. So whoever is administering the shot, and I'll always go like this because again, I'm old. I remember when you had the paddles. Now we put gel paddles on so that everybody is away from the bed. But you always, before you push that defibrillate button, you say clear off the bed. You look to make sure no one is leaning on the bed. No one is still on the bed. Again, it's a great way to shock whoever is still leaning on the bed. So you need to take that time to make sure it's safe. What's the difference between defibrillation and cardioversion? Does anybody know? So defibrillation, again, we got either a pulseless rhythm or disorganized activity, and there's nothing to sync up to.
Isn't the cardioversion, that's usually done with repeated AFib to kind of try to semi-permanently readjust a rhythm that's been shown to be dysregular for a while, not just one time.
Well, actually, Kristen, what it means is there is a discernible rhythm. There is electrical activity to sync up to. There is if you defibrillate on the T wave because of whatever polarized phase it's in, you can risk taking a bad rhythm that you're shocking to a worse rhythm. By cardioverting, which means you're syncing the shock to the patient's EKG. So it's almost two parts. You hook them up to the machine of the defibrillator, which monitors its heart rate and electrical activity. And it's going to time the shock so as to reorganize it, but not at a time where it will potentially make it worse. In almost all cases, you start with lower strength shock, lower number of joules. Joules is how you measure the electrical shock you're giving, and work your way up. So they'll often start, again, if we know of somebody who is a fib and is easy to cardiovert, they'll start at 25 joules, maybe 50 joules. If they're unresponsive to that, then you increase up to a maximum of 250 joules. So we try very hard to use the lowest possible because you can definitely get burns on your skin. And I'll tell you, those gel pads, the gel doesn't always go to the edges. And when they peel it off, you have a nice little imprint from where the electricity got your skin and there wasn't any gel protection. Feels like a bad sunburn. Not the worst thing, of course, but just yet another pain in the ass, if you know what I mean. Yep.
Is it true that with cardioversion that they usually try and sync it to the QRS?
Yes, you sync to the QRS. That's right, Sean. Yep.
And then defibrillation, they just kind of.
Yeah, there's nothing to sync to. So when you defibrillate, right? Again, you might give it a second or two to see what rhythm comes back. Check the EKG. But if you need a second shock to be administered, you got to do CPR and you got to provide oxygen in between. So remember that whoever is providing those services keeps on going until you hear the next clear order. Then they get off the bed, get away from the bed, and the patient can be reshocked. Again, old picture. Nowadays, you roll the patient, one pad goes on the back and the other pad goes essentially in the middle of the chest, and that's how the defibrillation takes place. Again, you got to maintain CPR, you got to maintain oxygen delivery while you're getting ready and just prior to shock and after shock. You need to make sure, even with whether it's with cardioversion, defibrillation, whatever, and you need to ensure that everyone is clear and away from the bed. And then you apply the charge. And again, synchronized cardioversion, we talked about that. Again, usually done at a lower energy. Nowadays, we have internal defibrillators. So for patients who have chronic ventricular tachycardia, in particular, some patients who have heart failure, that is a criteria for an internal defibrillator being placed. This is essentially a pacemaker that has a lead going in that's tracking the heart rate, the contractions. When it gets above a certain rate, it will release a shock internally to try to reorganize the electrical conductivity in the heart. Has anyone cared for a patient with an internal defibrillator yet?
Yes.
Yeah, I'd be shocked if you didn't see him on 5-7 fairly regularly also, as well as other units down in Stamford. Because again, like the advanced heart failures, I think it's New York state level, even 4, which I think is 6 levels, you qualify for an internal defibrillator because the risk of VTAC and VFib are so high, the internal defibrillator can make a difference. And it's a very low amount of electricity that's given in that shock. It's adjusted for each patient to see how much will actually turn the rhythm around or refix the rhythm. But it's still uncomfortable. Patients need to know, number one, they have a defibrillator in. They should know, maintain their little card, which gives its settings, its brand, batteries and information and stuff like that. They need to call if it goes off. They need to call if it keeps going off. It may need to be tracked. But most of these, both pacemakers and internal defibrillators, have such long battery lives now, it's amazing. When I was down in Johns Hopkins, I talked about the internship I think I did down there. I was on the research unit that was doing the first research on internal defibrillators. And the 2 physicians who invented them were the attendings on our unit. And they were also trialing amiodarone, had not received FDA approval. Took a long time to get amiodarone approved because it has some heinous side effects. But it was pretty, again, this just seemed like science fiction to me as a nursing student. I thought it was so cool to have it become essentially ubiquitous now. It is pretty amazing. Pacemakers. I talked about patients with complete heart block need a pacemaker. We need to make sure that patients are not sent out with that potential. So again, pacemakers can help maintain a regular rhythm with a sort of a little help to the heart. In most cases now, there are at least 2 leads, one going to the atrium, one going to the ventricle, so that we can synchronize the pacing action between the two. We know how important atrial kick is to cardiac output. So by stimulating the atrium, then stimulating the ventricle, you maintain the atrial kick with the pacemaker. Original pacemakers just stimulated the ventricle, and the pacemaker in the atrium did whatever it wanted to do. This is an EKG with a pacemaker spike. So in this case, we don't know whether there would have been a ventricular contraction without that little stimulus right there. What do we note about this QRS complex? Anything you want to say about it?
Wide.
It's wide. So we know that it's not traveling down the bundles or the Purkinje fibers. It's traveling its own pathway. So again, it's going to be wide and bizarre. It's not a PVC. This is a pacemaker-induced contraction. And in this patient's case, I don't see any P waves. It looks like we just have a ventricular pacemaker. Most pacemakers nowadays are what they call on demand. And so they are, again, complex electronic tools that monitor the contractions of the atrium and monitor the contractions of the ventricle, and only fire when the atrium isn't responding fast enough to its intrinsic stimulus, and only fires when the ventricle is not responding to its atrial stimulus. If the atrium and the ventricles are doing their thing within certain prescribed, programmed, if you will, rates, then the pacemaker just lays in wait until it's needed. When the heart rate drops below certain programmed rates, then it's going to stimulate the atrium or the ventricle. Or maybe the atrium's doing its job, but the ventricle's not responding. So the atrium won't spike because the atrium's doing its thing, but it will stimulate the ventricle to contract. So it can be, these are increasingly complex tools nowadays. But in each case, you're going to see a spike initiating a contraction. So now in this case, looking down here at the rhythm strip, well, what do we think? I think we've got a prolonged PR interval.
Where are the P waves? I can't actually see them.
So looking down here, that's a P, that's a P, that's a P. They're subtle, for sure, I think.
And then is that ST elevation in the second lead?
Yeah.
Exactly.
Yep.
the elevated P wave.
2, 3, and F. Yep. So yeah, and I think this is slow. I didn't count the rate. I broke my own rule. So this is pretty slow.
It's less than 50.
Yeah. So I think it's a sinus bradycardia with some good ST elevations there. This one again, in this case, and this is why it's important to develop a system to analyze an EKG, because your eyes start darting to many different things, and you're going to have to ultimately answer a lot of different questions. So just make sure that you're sort of dotting your I's and crossing your T's. So for instance, in this case, we have so our rate is a little bit faster than the last one, considerably faster than the last one, if you will. We have P waves and we have a QRS for each P. We're less than 0.2 seconds on the PR interval. Less than 0.2 seconds, did I say that? Our QRS is narrow, probably 0.1 or so. And then we can start looking again at our baseline. Well, looks like some ST depression in 1, ST depression in 2, 3, ST elevation in R, a little bit in L. Depression in F and V1, some depression in V3, 4, 5, and 6. And then we can, our P waves, we have upright P's in 1, upright T waves, upright in 2, upright 3, downward facing P's in R, down, T's. Hard to find an L, but our T is definitely going down there. Upright in F, upright. I think that's what Eugene calls, kind of 50-50 there, but upright on the T's, I should say.
That's a clear ischemia or maybe infarction that's STEMI anterolateral, first, second, and
Right.
V4, V6.
So this EKG,
Yep.
a little tachycardic, just about 120-ish, 100
Yep.
or so.
Something like that.
We got our PRs are okay. So it looks like a sinus tachycardia, but we've got ST depression and ST elevation sort of throughout. And when you say, now we need to start grouping Where do we see elevation and where do we see depression? So make sort of that list. We talked last week and I said, hold on, I'll answer this question because we talk about a 12 lead EKG, but we only have 10 wires. Why is it called 12 lead? Well, the wires get placed, the 10 wires get placed. You have your limb leads, right arm, right leg, left leg, and so that's 4. And then you have 6 precordial leads, which go from the 4th intercostal space. The right sternal border is V1. 4th intercostal space, left sternal border is V2. Then V3, 4, 5, and 6. Those are called your chest leads or precordial leads. And what these 10 leads measure are 12 different views of the electrical conductivity through the heart. Those 10 leads show these 12 different views of conduction through the myocardium. And each of these leads, 1, 2, 3, AVR, AVL, AVF, V1, 2, 3, 4, 5, and 6. Each of these show a different area of the left ventricle when you group them together. For instance, lead 1 and lead AVL are the lateral wall of the left ventricle, excuse me. Lead 2, 3, and AVF actually shows the inferior wall of the left ventricle. V1, 2, and 3, again, if you look at where those are placed, 1, 2, and 3, that shows the anterior septal wall of the left ventricle. And then V4, 5, and 6 shows the more posterior and lateral wall of the left ventricle. It's important to remember that the typical EKG is really looking at electrical conductivity through the myocardium of the left ventricle. If you wanted to see what was happening on the right ventricle, or you wanted to see if you had a patient who had dextrocardia as a congenital anomaly, meaning the heart was flipped, then you would have to take these chest leads and reverse them. So V1 would be on the left sternal border, V2 would be on the right sternal border, and then 3, 4, 5, and 6 would go across the right side of the chest. Again, this is just a quick picture of what each of these different leads is sort of measuring. What we know about ischemia is, and ischemia is showed by ST segment changes and T wave changes, is that, again, ischemia is a mismatch between how much oxygen is needed in the myocardium and how much is available. So again, ischemia shows up as ST changes or T wave changes. Elevation is acute infarction. So infarction means there is beginning to be damage to the myocardium. Depression is a sign of ischemia, which means not enough blood, get me some blood. Excuse me, not enough oxygen, get me some oxygen. And then T waves can flip, again, in relation to the P waves, again, also a sign of ischemia.
Hey, Carol Ann, just a quick question.
Yes.
For non-STEMI,
Yeah.
What is, I mean, you know what an ST elevation looks like, but what does a non-STEMI look like?
A normal EKG.
Just looks like a normal, the guy's having a myocardial infarction, you can't see it on the EKG.
That is true.
Wow.
So how do you measure that?
Probably the BNP, I don't know.
No. You know what measures
Troponins.
what?
Troponins.
Troponins and CPKs, CPKMBs in particular.
Okay.
So you need to watch those labs.
Okay, cool. Thank you.
No problem.
Tall, sharp T waves. You can be suspicious
Suspicious
of that.
for T waves, right? But
Or it may be hyperkalemia, so you need to look at the clinical picture.
I was just going to say, you need to take that whole picture into consideration. Exactly. And, you know, again, the concept of a non-STEMI, non-ST elevated MI, I'm going to say didn't exist until mid-90s, maybe? Didn't know they existed.
Until fast markers like troponin and MB fractions were discovered. Otherwise, you just cannot judge. So if it's a damage or just ischemia.
Right. Now, when I say remote ischemia, shown by, what do I mean by remote ischemia? This is sort of a classic physical history word. We think of remote as being far away. When you read remote in your medical record, it means a long time ago. So remote ischemia means happened in the past. So this is a patient who's either new to you or all of a sudden comes for their physical exam or has something else going in. You do an EKG and they've got Q waves. That means they have had a myocardial infarction. The myocardium has remodeled and there is a change in the way that electricity is conducted and it shows up as a Q wave. And we never saw ST elevation. We never saw ST depression. We never saw anything. Patient never complained of anything. It happened in the past. It's old. That's what we mean by remote ischemia. And again, ST segment, I always look to before the P waves. That to me is my baseline. And then I look at ST segment, again, that from where the S ends and the T begins, that's the ST segment. And we want to know, is it up or is it down? And then this is, again, our inverted T waves, as in Tom, is always in relation to the P waves. P's and T's go in the same direction unless there's a problem, and then the T's, that's what a flipped T is. We used to think that the higher the ST segment elevation, the worse it was. There's a modicum of truth to that. It's why we used to call them tombstone T's. You know, nice big rectangles instead of nice flat curves. So again, here we've got, you know, let's not necessarily read the rate and the rhythm per se right now. Let's focus on ST segments. We've got depression. And so again, when I look at STs, because I've already learned 1 and L are related, 2, 3, and F are related, 1 through 3 and 4 through 6. I still don't understand why we need R, but it's always there. But again, I'm going to look at 1 in L and I see ST depression in 1 in L. I see slight elevation in 3, flat T's in 2, and some elevation in F.
Carolyn.
Yes.
It looks like an infarction, and I've seen it before. That's the dextrocardia.
Oh, really?
And it says here, right-sided chest leads.
Oh, you're right.
I think, yes, that's what it is. And it's scary when you see it. So, but if patient feels well, so just keep in mind to maybe listen and take it symmetrically on the other side.
Well, the other thing is that if you have a patient that has and inferior wall ischemia,
Yeah,
their
but
chances of an RV infarct is something like 60 to 70%. And while we think of the left ventricle as being the main work pump of the heart, clearly a decline in right ventricular function is of concern also. So whenever you have an RV an inferior wall infarction, you're also concerned about the right ventricle also.
yeah, that may be the combination because there is ST elevation on two, yes, and the third and V4.
Yep.
Yeah, depends on yeah.
Yeah.
Okay.
So what we've done today is we've gone through the different dysrhythmias and given you examples of what those pictures look like. I'm going to ask you to, hold on, I'm gonna stop share for a moment and show you something else on, what's that called? Husky CT. I want to start share again. I want to go here. I want to go here. I want to share screen. I don't think I want to do this one. I want to share. So there's quite a bit of collateral information this week. Some of the shorter ones are great in terms of explaining stuff. I think that I would strongly recommend checking those out. And if you end up in an ICU, ED, or a telemetry unit, check out some of these other videos. YouTubes they're very good about further clarifying dysrhythmias. And then there is another one. This EKG rhythm and analysis, this is from the University of Toledo. It's probably the best EKG class I've ever seen. This isn't a video. This you can print out or review online, but this is pretty awesome. But what I want you to do, in addition to your other preparations for next week's quiz, please look over this ACLS rhythm program. So if you click on each of these buttons, again, it will ask you some questions, give you a little bit of an information, and show you a rhythm that relates to the type of dysrhythmia. And I think these are very nice tracings. We know in real life that not all tracings are not nice and neat and easily readable. You will definitely have people, is that really the P wave? Can we get the patient to stay still? You never quite, there are certainly lots of tracings out there that are less distinct than this, but I think they've chosen some nice ones in this program that you may see again, if you know what I mean. Does that make sense to everybody?
Yes.
Yes.
Thank you. And if it works out, we might be able to do a fast drill or a Jeopardy, or maybe I'll post a Kahoot. That would probably be the best bet, so that you can do it at your leisure, or perhaps within your clinical groups. That would be awesome, wouldn't it?
Yeah, that'd be great.
Yeah, Kahoot will be great.
Yeah, I can definitely do that. I can commit to that. But again, this ACLS is quite good. There was an even better one, but they started charging for it this year. I'd be cheap. All right. So listen, guys, go take a bio break, do a stretch, come back at 12:15, please. Get any questions you have for me, you know how to find me. I'll send out a blueprint, I'll post a Kahoot, and I'll see you at 12:15, okay?
Okay.
Hey.
Yeah.
Good. Thanks, Caroline.
Thank you.
Thank you, guys. It is a different link, you know, you got another one. And I corrected it. Make sure you click on the one that's for 12:15. I was an idiot. Thank you. Bye, guys.
Bye.
Thank you.
Bye. Thank you.